This week's episode is one I've been wanting to bring you for a while. I'm sitting down with Justin Laffoon, the Director of Clinical Services at the BridgeWay, to talk about what's really going on inside our mental health system and what we can do when someone we love is struggling. We dig into what works and what doesn't when someone is in crisis, why safety planning is so much more than a checklist, and how even a tiny gesture can shift the trajectory of someone's life. If you've ever worried about saying the wrong thing or not knowing what to say at all, this episode's for you. Welcome back to the Suicide Prevention Lady podcast, where we make intervention easy. I'm your host, Dr. Rikki Turner, and I am a suicide intervention expert. Please take note, I am the thinky kind of doctor and not a medical professional. So please do not take anything you hear in this episode as medical advice. Here's Justin. All right, welcome to the podcast today. We have Justin Laffoon. He is the Director of Clinical Services at the BridgeWay in Little Rock. Would you like to tell us a little bit about about yourself and what you do?
Yeah, sure. So I'm a social worker by training. I received both my BSW and my MSW. I got my BSW at Arkansas State in Jonesboro, and then did my MSW at UALR. I've predominantly worked in psychiatry, so I've worked mostly in inpatient settings, and I did do a few years in outpatient when I was much younger, but mostly I've worked in facilities like the Arkansas State Hospital, or I've also worked for Baptist Health in their psychiatric unit, and then also now I work at the BridgeWay. So I've been doing that for almost 20-something years now.
That's awesome. Thank you so much for the work that you do, because that is not slight. That's a heavy field to get into for sure. How did you figure out that you wanted to do this for your career?
Well, it wasn't something I grew up thinking I was going to do. I really thought I would probably end up being a doctor. That was kind of something I always was interested in, and my mother, of course, encouraged. So I thought I was going to go to med school. School just it seemed like I started thinking about, oh my gosh, 4 years of college, 4 years of med school, 4+ years of residency. And so I was really trying to figure out what I wanted to do maybe as an alternative to med school, even considering maybe doing like nursing and getting my APRN to become a nurse practitioner, which would have kind of shortened the amount of time I had to go to school. And while I was kind of in between majors and thinking about what I wanted to try, one of my really good friends growing up, her mother is a social worker, and she was like, hey, just take intro to social work, see what you think. It's, at the very least it will count as an elective course. And so I took the intro to social work class, and I loved it because it was so many different things. There was a lot more versatility. I didn't really know what social workers did other than what we see in media portrayal. So working for DCFS, taking children from homes, stuff like that. So then I figured out, once you get into it and you learn, well, no, it's more than that. It's advocacy. It could be political work. It can be mental health. I didn't even know that social workers could be mental health practitioners. And so then I kind of started getting interested in that aspect of it. Like, oh, I could still work in the healthcare field, but not necessarily have to go to med school. And so, yeah, I ended up pursuing my bachelor's and then went on to get my master's.
That's awesome. That's so cool. I like following how people's trajectories go, because it's like,
yeah.
Justin and I met when we both worked at the University of Arkansas Little Rock, and I don't think either of us, as little kids, were growing up going, I want to be a student development specialist.
No
one.
I mean, even when I thought I was going to go to med school, I was going to do something more like trauma medicine or something that had a little more quote unquote prestige. I was never going to be a psychiatrist. So yeah, it's funny how my trajectory ended up here.
Any college students who are feeling weird that you don't have your major picked, take the elective class. It will pay off, I promise.
For sure.
And it's okay to take the elective class and then figure out that's not what I want to do. You just took a portion of a year instead of a whole lifetime to figure that out.
Exactly.
Yeah. All right. So Justin is a little bit of a local celebrity here. He was on the news this last week for talking about the uncertain future of the suicide prevention hotline. Can you tell us a little bit about that?
Right. So the segment I recently did on Channel 7 was because, there's been a lot of funding cuts at at the CDC and just within the Department of Health and Human Services in general. And one of the big ones I think that they were kind of picking up on was the cuts that were being made specifically to 988. And those cuts right now so far are only really affecting kind of the ancillary hotlines that they have that are specializing for certain populations like LGBTQ, for Native peoples, but it's also affecting things like people who are hearing and sight impaired. And so those, you know, while those cuts are the ones that are happening immediately, we're seeing how kind of expansive these cuts are becoming. And so there's really concern about whether it's going to be able to sustain the hotline overall.
Yeah.
So, I mean, it's really scary, to be honest.
I have major concerns about that as well. And because I hear, you know, I have a good following on TikTok, and I talk to survivors and people who struggle with this on the daily, and they're constantly reporting about the long wait times for the hotline. Like, I tried to do the hotline, but you know, it was 4 hours later and no one was talking to me and stuff like that. And I'm like, it's really scary to think what's going to happen.
I mean, a 4-hour wait time, you might as well just go sit in the ER for
right.
You know, that. That is concerning, because even you know, like a window of 30 minutes is the difference between whether somebody decides to complete suicide or whether there could be an intervention that could be implemented to help them, you know, in the immediate.
Yeah.
So
seeing those wait times, it's already concerning. And then just to think, and now we're going to cut resources from that. Like, I can't make that make sense in my head. How?
Oh, none of it makes sense. And you know, not to make the podcast political or anything, but if you've been watching, you know, the news, they just brought the Secretary of Health before Congress yesterday, both in the committees for the House and for the Senate, where they grilled him on, you know, you've made these cuts, and his claims are, well, none of these services are going to be disrupted, but you've fired all of the staff, in some cases the entire staff that covers those areas. So you can't really make the claim that services aren't going to be disruptive if there's nobody there to answer the phone line or to do the research. So
right. And I have concerns too. I know that you know, they're cutting the specific, like the LGBTQ and all of those, like the ones that are under the umbrella of DEI, which I've already had a whole podcast on what DEI really is versus what it's been labeled as. But I don't know. And I know, like, this is something that for me, I'm like, okay, so are you telling me that those lives are okay to lose to suicide? Is that what you're telling? Like, because that's the message that's out there, is that we don't value these lives as much as we do others. I don't know. What's your take on that?
Well, I think the narrative that has been, and I think one of the arguments that I've been able to successfully get across to people who bring this up, is they say, well, why is there a special line for LGBTQ people or for you know, people who are of Native descent? And I'm like, it's not that there's a special line. It's that you already have 988, which is available to everybody. The suicide crisis line is open to anybody, but these extra funds were so that people also have training in this particular area and dealing with these particular issues. So anybody who just answers the crisis suicide line is not going to necessarily understand what somebody who's going through, if they're struggling with their sexuality or if they're living in an environment where they're not being accepted, versus, you know, someone who's just feeling really hopeless at that moment. And so it's not taking away from anybody else. Those people that are manning those lines could probably also answer the phone and help anybody else if they're not busy, to just deal with other, you know, what we consider more general run-of-the-mill issues that are going on, versus, you know, but someone calls in who's experiencing those issues, and that person who answers the line really doesn't know what to say or how to help them in that moment with that particular issue, you know.
Right.
So I think that there's a misconception that this was a special dedicated line that only helps people with that, but it's more about having people who are trained with these issues, so that when someone calls in with that, they get transferred to that line and they get that specialized assistance that they need dealing with those issues.
Yes. And you touched on a good point, and I kind of want to build on it. The empathy that can come from somebody who has been trained to deal with those certain populations. That can be the difference in life or death. And I don't think people understand that. I feel like from the outside looking in, if you've never been a part of this community, if you've never been a part of this movement, your suicide prevention movement and everything, then you may not understand that. You may be thinking, well, don't you say the same thing to everybody? Or like, isn't it the same kind of protocol for everybody? And the vast reasons that people can be considering ending their life, I mean, it can be just all over the map. And I feel like it's not my place to judge why you're considering ending your life. Like I'm not in your shoes. I do not know why you've come to that conclusion. I can only listen, empathize, and try to connect with you on a human level and try to put in some sort of intervention that keeps you here a little bit longer, so that, like, the goal is not for them to call the suicide hotline and then us talk to them and then be like, okay, now I'm good, I'm all cured, and go on about the life, right? Like, it's a stopgap. It's a, let's get them through this moment so that they can then get the momentum to get some help. I don't know. From the clinical side of things, from your views, can you help explain that in maybe a way that I didn't hit?
No, I mean, that's exactly it. So when someone is feeling hopeless in that moment, it doesn't mean that in a few days they may not feel hopeless again. But if they're feeling so hopeless in that moment that they feel like the only way to make that pain end is to kill themselves, then yeah, the intervention in that moment is just to get them through that period, and get them plugged into the services that they need, that then will help in the long term. That doesn't mean that, say in a week or 2 weeks that they're not going to feel that again, but you've got to, if you don't put the intervention in place right in that moment, then, say they do kill themselves, then you don't have a chance to intervene anymore.
Right.
Yeah, and the point of that suicide line is not to fix people, and that's not the point of a hospitalization either. When you come into a psychiatric facility, the point is to stabilize that person to the point that they can then access the resources that they need in their community, and hopefully find some long-term solutions.
So that brings us to a good point. So, and you know this, I talk a lot on social media, and I talk about suicide prevention, and I talk about things that you can do, and just anything you can do is just the run-of-the-mill average person, not somebody trained in social work or counseling or psychiatry or whatever, but just somebody who loves somebody else, and now they are considering suicide. What do I do? When I talk about that online, I get so much hate for saying that if all else fails, get them to a residential facility or get them to the ER so that they can be safe. And oh my gosh, I've had people just come at me like I am the devil on earth. I am here for the downfall of man for recommending that.
Do you know, is it people that have had experiences in the hospital before, maybe, that are?
There are, it comes and goes. So some people, in their defense, some people will comment, and like they'll come to my defense in the comments and say, residential was the worst experience of my life, but it saved my life.
Right.
And so if I had to do it again, I would do it again. Like so many people, but then there's the couple that'll just, they're louder than everybody else. And they'll be like, I have never had so much more trauma as I have in my residential hold, and blah, blah, all this stuff. And
Right.
we're causing harm by telling people to do this. And
Right. No, and listen, most of my career has been inpatient. So that has been the predominant experience of my career as far as what I've done in psychiatry. And even having done that and been in this for that long, I do understand why people are upset about that and why they say those things. And there is an extent of that where there's a lot of truth. This is not a fun environment to be in. It's not a fun experience when you have to be hospitalized. It is nothing like going to a hospital, say if you break a bone. You're going to get to go to a room where you have open access. Your family can be there with you. They can visit you. You can have your cell phone. You're going to have a TV in your room and be able to have a lot of freedom to walk around the facility and do whatever you want, go out inside. you don't get that kind of freedom when you're here for behavioral issues, particularly when it's something that has to do with being a threat, imminent danger to yourself or to others. So that experience is very traumatic. You come into a locked facility where suddenly your freedom is to leave is no longer there. They take away all of your personal belongings. You don't get to have a cell phone when you're in a psych facility. They take away any objects that you might have that could present a danger to yourself once you're on the unit. So there are no strings in drawstring pants. There are no shoelaces. You can't even wear a bra with underwire in it, because those are all things that could be used to self-harm. And even though there are a lot of people who would never do any of that stuff, even the ones who are actively feeling like, I want to end my life, there's enough instances of people who did try to do those things that most facilities just have to have a blanket policy where we cannot accept that. And so for people who've never been hospitalized for those reasons, this can be a huge shock. It's a big culture shock. So there are those people that you've heard that have said, that was the worst experience of my life. I never want to do it again, but it saved me, because that we got them somewhere where they couldn't do those things that they wanted to do, whether it was they wanted to harm somebody else or they wanted to harm themselves. But then after they got stabilized, they were able to get back to the community provider, and they were able to go through therapy, maybe get medication adjustments, and then they were able to move forward with their lives. Then there are people who maybe had already experienced trauma before they had come to the facility in general. And when they're in those moments where they're losing control, and yes, maybe something like a physical hold was initiated in order to keep them from harming themselves or harming others, it can be re-traumatizing. And we're fully aware of those things in inpatient facilities. And while there's a lot of things that we've changed over the years, even in the 20 years that I've been doing this. So going into the mechanical restraints, we don't strap people down to beds anymore. We don't do 5-point restraints in chairs anymore. We don't lock people in seclusion rooms. So some facilities still do use a seclusion area in the most extreme cases, but that's like the absolute last resort that you have to do. For the most part, all facilities now do what we would initiate a physical hold, and we just hold that person. And it's not just one person, it's several people holding them in the safest position possible, so that we can make sure they're still able to breathe, and that they're not, that there's not going to be a lot of issues. And we hold them as long as it takes until they can calm down. There were a lot of times where, like you would see in the old movies, where they would throw them into a room, shut the door, and just leave them there. They don't do that anymore. They've even become a lot more aware of chemical restraints. When I first started in this, it was common practice to give the patients what we called a 10 and 2, 10 of 10 of a Haldol and 2 of Ativan, and you would just put them to sleep. And now they're looking at those policies now and saying, hey, you can't just have somebody who's sitting around in the day room drooling all the time because they're so over medicated. We're really working on those policies to make sure that the interventions that we do put in are as the least restrictive as possible while still maintaining their safety. And so I get those things, why people say, I hate this and I would never want to come back there. And in some cases, I look at that as a good thing, because then that's a motivator for that person maybe to access resources and get help before it gets to that point. For other people, I wish that there were things that we could do to mitigate those traumatic things that can happen in the facility, like being held down. But at this point, we don't have anything better to do. So those are kind of the last resort things that we do in order to keep them as safe as possible. And then we just have to work with them after they calm down and process through, like, hey, that must have been really scary for you. Well, it was also scary for us because we were afraid that something bad would happen. We were just trying to protect you. And I don't think that hospitalization is necessary for everybody who says that they're feeling suicidal. So, over the course of my like becoming more knowledgeable and gaining more experience, I think we don't do enough education even with clinicians on suicide assessment. So being able to better differentiate between what passive suicidal ideation is versus active suicidal ideation, having a plan, having access, and so then also being able to create a comprehensive safety plan with that person so that maybe they can avoid an inpatient stay. I've had patients in the past where they said, you know, I feel like I'm ready to end all of this. I don't want to do it anymore. I know how I would do it. I know I have access to it. And so when we started that conversation of maybe we need to be in the hospital, and they were like, absolutely not. I'm not going to go to the hospital. So then I was like, okay, well then here's what I need to see in order for me not to initiate the process. And that's, do you have somebody that a support person that we can contact that will come up here and will allow me to educate them on what we need to do, that we can go through the plan on how we're going to secure those lethal means so that you don't have access to them. And then what are we going to do in the time period until you can get to see your outpatient provider? And as long as we have all of those steps in place, and that person is willing to take responsibility for that person, then okay, we don't have to do a hospital stay.
Yeah.
So, I mean, there are other options. You don't always have to do a hospital, but sometimes that is necessary. And even with the things that can happen that can be traumatizing with a hospital stay, it would still be better in the long run for them to go through those things rather than to end their life and not have the opportunity to recover from that moment.
Right. I could not agree with you more on that. Especially when people are talking about it, I feel like they're acting like I'm like, everybody go get a hospital stay for you and a hospital stay for you. And I'm like, no, there are two things for me that are last resorts, just absolute last resorts: calling the police and an actual, like, taking them to a residential stay somewhere. Both of those, to me, they are absolute last resorts. I have done both. Like, I have called the police. I've actually taken to BridgeWay specifically. Like, I have taken people to the ER or to a residential facility, wherever. And I don't take that lightly. And
it shouldn't be taken lightly.
Yeah, that is a, you're making that decision because you are out of options. And you are scared that this person is not going to make it through the night or whatever. I hate it. I have seen both scenarios go really wrong, and there's been times too, where I've taken somebody to the ER knowing in my bones they are going to be admitted. They are going to be admitted. This is so serious. And they get in and they're not admitted and they're released. And I'm always like, oh gosh, where did I go wrong? Like,
you didn't necessarily, when they do those assessments in the ER, sometimes people, especially the longer people do this, they do gain an understanding. They know what to tell the people in the ER in order to get that release. It's really important for the support people to also be present in those situations so that you can give them some collateral. Because even from our perspective, when we can have people walk in here at any time of any day to be assessed, and sometimes people do come in and they say, oh yeah, no, I was feeling suicidal earlier, but I'm not feeling suicidal now, because once those doors click, people's mindset change and it becomes more of like, how do I get out of here? And so if the support person comes with them, if they're there and we say, hey, can you tell us a little bit about what you were saying, and we get that collateral information from them saying, oh no, like 5 minutes before we got in the store, they were actively telling me how they were going to end their life, then those are things that we can take to that attending physician. It's also things that we can use for things like a 72-hour hold to at least get them some help for a couple of days to get them stabilized before they go. Because like I said, once they get behind those locked doors, for a lot of people it becomes, okay, now what do I say? What can I do in order to get out of here?
Right. Yes. Again, thank you so much for what you do. And it's such a hard job. That's a heavy job. And I have a different question I didn't think I was going to ask, but as somebody who does a heavy job on the daily, how do you separate? How do you create those boundaries? How do you protect your own mental health?
It's really not easy, particularly when you're young. I have not had any patients that I actively treated that died by suicide while they were still my patient.
Mm-hmm.
But I have had patients who I've worked with in the past that later on went on to kill themselves.
Right.
And that is, particularly if you're actively treating someone, that is really hard on particularly a younger clinician, because you feel, you just like family members do, you
Right.
automatically start asking all the questions like, what did I do wrong? What could I have done differently? What should I have said? All of those things. And so all of that kind of comes with age and with experience and wisdom, and knowing that you can't save everybody. As much as you want to, you can't save everybody. And even in the cases where, yes, we say we want to end suicide 100%, the truth is we will never get to 100%. If somebody wants to end their life and they're in a situation where there's not anyone around to intervene, they're probably going to be able to do it. And then you have people who maybe are under the influence of something that it's more of an accidental, like using with guns and other situations like that. But so part of it is learning that you're never going to be able to save everybody. But the other part too is, I think, and it takes a long time, but you have to learn that when you close your office door at the end of the day, everything that's here right now is going to be here when I get here tomorrow. And I can't carry that home with me, or else it's just never gonna, you'd burn out too fast. And I think there are people who don't learn to do that, and they are the ones that burn out and have to end up leaving the profession. You just can't take it home with you, or it becomes way too much. I'm not here to save the world, but if I can make a small difference in somebody's day that day, or a small change or a small improvement to their situation that then will start to snowball into other improvements, then at least I've done some good. I'm never gonna fix everything, but but the point is every day to come in and try to do something that's going to move the needle just a little bit.
Yeah. And you kind of stumbled into the whole prevention, like my whole prevention talk of like, you don't have to do these Herculean things. You do not have to go in and wrestle the lethal means away from them. You don't have to be that person. And what I teach people to do is I give them an a la carte menu. It's intervene with ease, EASE, and just pick one. Start with one thing from the menu, whatever you can do at the time, and let that be your intervention. You can do all four if that's what's necessary at the time, but you can express care to them, let them know that they're cared for and that you see them and that you love them in some way. We're not love bombing, where we're just letting somebody know they are a valued human being just as they are. We can ask them directly, hey, are you thinking about hurting yourself? Are you considering suicide? You're not going to give them the idea. You're not going to make them think they should.
No, exactly right.
People already, they already know, they already think about it. They either want to or they don't. And so it's really just a yes or no question. You can show up for them. You can, it's one thing to say, hey, I'm here for you if you need anything. Hey, let me know if you need anything. And there's another thing to be like, Justin, I haven't seen you in a while. I'm on my way. Do you want chicken or tacos? Like I'm bringing dinner, choose one of these two, because I'm going to stop and get it on the way to your house, or, whatever showing up looks like for you.
Right.
Or if nothing else, if you don't feel comfortable or you're not in a role where you can do this, get somebody else and trust somebody else is the last E. That's where you're calling a sibling or a friend or a spouse or a family member or a priest or a therapist or the emergency room or wherever, but you're getting that other person who is better equipped to handle that than you are, and you're getting them involved. And all this started, I think you might have been at UALR at the time. It might have been before your time, but this all started because we had a really large spike in suicides.
Right.
and suicidal ideations. And when we talked to the faculty members of those students, everybody noticed something was wrong with the student. Maybe not necessarily thinking that they were suicidal, but they
Right.
noticed something was different, something was off, something was going on with the student. But none of them intervened in any way. None of them checked on the student. None of them reported them to counseling or the dean of students. You know, nothing happened. And speaking of younger professionals, I was a judgmental heifer back then. And I was indignant with rage that this was going on. Like,
Yeah.
I could not fathom just leaving these students out to figure this out themselves. But what happened, what we found out was they didn't feel empowered to do so. They didn't think it was their job. They thought it was illegal. They thought that they could get in major trouble for doing this, plus all the other myths that surround suicide. Thinking they're going to give them the idea or something like that. All of those different things. Thinking they're only doing it for attention. It wasn't really serious. All of those things. And I can't help but go back and think, how many could we have saved?
Right.
Had somebody who noticed something was going on done just simple things, just, you know, one of those simple things. And I don't know, when you were talking about, you know, that must have been so scary for you, and empathizing with a patient or a client, even those small little things like that can sometimes be the breath of fresh air that gets them to the next day.
Right.
And I just, yeah, I lost the train of thought of where I was heading with that, but it started with that whole.
Yeah, you're absolutely right. Brene Brown has this great example she gives about sympathy. And she's created a little video now that's on YouTube where they kind of got some animations to it. But it was probably one of her TED Talks where she's talking about, but like when you think about empathy versus sympathy, empathy is someone is down in this dark hole. And so sympathy is where like this person pops their head at the top of the hole and they're like, oh, hey, I see you're down there. That's too bad. You want a sandwich? And whereas empathy is someone gets a ladder, they climb down the ladder, and they just get down in the hole with that person. You don't have to say anything. You don't have to do anything. You just have to say, you know what? This sucks where you're at right now. And I'm just going to sit with you in this moment and be with you. You don't have to say anything profound. Like you were talking about, you don't have to do the love bombing. The love bombing is not going to make them feel like their life suddenly has value or meaning. Just having somebody that's going to sit there in the darkness with them for a little while and say, hey, I'm going to be here with you. And when you're ready to talk about it, I'm here to listen. And when I teach graduate students, you know, when they're starting like to learn like the basic principles of therapy, most people are always very scared of like, what am I going to do or say? Am I going to say something that might ruin their life or mess everything up? And I'm like, I tell them 99% of effective therapy, all of the theories you can learn, all of the modalities, the different types of treatment you learn, that have all these great little tools and things you can do to help patients improve and progress. All of that is maybe like 1 to 1.5% effective. What's 99% effective is if you're actively listening to them, if you're hearing what they're saying and you're validating how they're feeling in that moment, because that's where a lot of the weight is lifted when somebody hears them and says, oh my gosh, that must be really awful, and I'm sorry you're going through that.
Yeah.
And not fixing it, just saying, just acknowledging that, yeah, you're in a really tough spot right now.
Yeah. Yeah. I mean, women have been saying that for years to their spouses, right? Don't fix it. Just listen to me.
Yeah, just listen.
When you were talking about, you know, when you leave, you know, you shut the door and you're like, I've done my best today. I've given some glimmers of hope. It reminded me of the story of the starfish. Have you ever heard this?
Oh, no, I don't think so.
Okay. So it's this, a man goes on a walk on the beach every morning and sees all the starfish that have like beached, you know, and so, you know, they'll dry out and die. So he picks them up and throws them back. And somebody else is watching every morning this guy do this and go, why do you do this? So goes up and finally asks the guy, why are you doing, like, you're never going to save all of the starfish. Like what you're doing doesn't
Right.
matter in the grand scheme of life. You're not actually helping. And the guy was like, picks up another one and goes, but it matters to this one, and then throws that one back in. And it's like, we don't all have to, we can't do it all. We just can't. And you'll get bogged down trying to do it all. But you can do what you can when you can. You know, you can love on people. And, you know, at the end of, right before this podcast, right before this, at 11, someone called me out of the blue that I had not talked to in years. And I was like, why are they calling me? What's going on? You know? And when I got on the phone with him, he said, you just popped in my head, and I thought, I'm just going to call. When someone pops in your head, just go ahead and call, you know, like send them a text saying, hey, I'm thinking about you. How are you doing? Little things like that. Like, you know, if I did that to you, if I just did that on a random Wednesday and be like, hey, Justin, you just popped into my head. How would that feel? Right? Like it gives you a little boost, right? It's like, oh, someone thought of me. You know, it feels good. But I've done it a couple of times, and twice so far, when I got somebody and they were actually in the middle of an attempt or about to attempt. One was they had just taken, trigger warning, I guess, but they had just taken a bottle of pills, and they said, how did you know? And I was like, how did I know what? And then they said, I just took my bottle of whatever. I don't remember what the drug was. And I was like, oh my, I didn't know. Like, there's no way for me to know that. You just popped into my head. And then another one, very similar. They had not taken that step yet, but they were considering it. And that all came because somebody popped into my head and I texted them, you know, like there's so many small things that we can do that end up being so much bigger than the actual action. Like, I think people lose track of.
Well, and there is not in just necessarily in that, but like people who were discharged from psychiatric facilities. I can't even remember the psychiatrist's name now. It's been a while since I've referenced it, but he started an experiment in the 70s, late 70s, where after someone discharged from a psychiatric stay, they would, within like a week or two, send them a letter just saying, hey, we remember you were here in the hospital. We hope everything's going well. We're just checking on you, and we want you to know that we're thinking about you. And it was a handwritten letter. And they did this over a period of time, and they found that the suicide or the readmission rates for those people were significantly lower just from receiving that letter and having somebody just reach out and say, hey, we know you just went through a tough time, and we wanted to check on you and see how you're doing.
Yeah, there's so much power
having that connection.
That exactly, the power of connection. So many times it's this lack or not feeling seen or whatever, and that can be, I don't know, so powerful. Before we started recording, you started to talk about something, and I want to dive into that if you want to. You were telling me about the first time you encountered somebody who was suicidal, and this was in high school. Can you tell us that story?
Yeah. So I was it was my freshman year of high school. I had a friend, and we actually well, we'd known each other for several years, but we also worked together at McDonald's, like our high school job together. And she had lost a family member, was going through a really tough time. And I just remember that she disappeared from school for like a couple of weeks. And nobody at first really knew what was going on. And then right before she came back, a couple of people who were her friend, they're better friends, like they were actually like best friends. They were letting some people know, not like in a gossipy way, but like, hey, she tried to commit suicide, you know, because back then that's still how we referred to it, and she's gonna be coming back. And so I just remembered that so vividly back then, because we sat next to each other in one of our classes, and I just felt so awkward when she got back. Like, I didn't know what to say. I didn't know, do I acknowledge it? Do I do I say, hey, I'm glad to see you back, even, or anything like that? And that just always stuck with me. Like, I always felt bad too later on. Like, I just pretended like it never happened.
Yeah.
And later on, when I started studying social work and I started getting more into mental health, I really I really struggled with how I behaved then. And so I reached out to her because we're still friends to this day. And I said, hey, I just wanted you to know, I feel really bad about the way I behaved back then. And now knowing what I know, I wish I had done things differently. And she was very gracious about it, and, and said, well, none of us knew what to do back then. Of course, she didn't even know what to do, but that always stuck with me. And that's one thing that I always try to, and one of the reasons I love the work that you're doing in trying to educate people more, to end the stigma, to not be afraid of asking people, hey, do you plan to kill yourself? That's one of the things, like, people are so like, how do I ask them? You just ask
You
them.
just ask.
Don't use weird terms like, are you planning? I don't even like, are you planning to harm yourself? Because that's not. If harming yourself and killing yourself are two very different things. So being upfront and being
Yeah.
able to just be open about it and honest about it, have a conversation, and then even after somebody has made an attempt, being able to be open and honest about it and say, hey, I didn't know you were struggling, and I'm really sorry. So being able to educate people, not feel awkward about having those conversations, because I think all of us do at some point in our life have some type of passive suicidal ideation when things get really rough and when you're going through a bad situation. It's not unusual for someone to think, man, I wish I could just go to sleep and never wake up.
Yeah.
It doesn't necessarily mean you're going to do anything to make that happen, but we all have that feeling. So why is it not okay for us to talk about that and to acknowledge that we're having those feelings?
Right. Agreed. My audience is kind of broken into two groups. It's pretty evenly split. Some are listening because they find some community and comfort in somebody talking about it because they're suicidal themselves, and it's kind of like a safe space for them. The intended audience is for people who just don't know what to do. There's somebody in their life that is suicidal for some reason, and they're looking for guidance on what to do.
Yeah.
So from your standpoint, from your lived experience, your professional experience, all that put together, the first question I have is, what do you hear that people do that they think is helping, but is actually kind of making the problem worse for the people who are considering suicide? Might be well-meaning things, but
yeah. Well, I think the love bombing thing is one thing that, like, just the trying to tell them, tell them all the things that they have to live for. Not that it's not important for that person to understand they do have those connections, but in that moment, it's just not important to go over all that stuff. It's more about being present in that moment, acknowledging that things are really bad right now, and then working on a safety plan. There was a time when we used to do what we called a safety contract. Those don't work. There's no evidence to show. Signing a piece of paper that says, I won't kill myself, is not going to keep someone from killing themselves. What's important is for them to know what resources are available in a moment of crisis, who are the key people they can turn to, and what are the things that they can do when they're feeling really upset that help to kind of ground or center themselves, whether it's deep breathing or if there's certain like sensory things that help. So just just don't try too hard. It's not about, you're not there to quote unquote save them. You're there to be with them in that moment and just be present and let them know that you're there, and that you're going to do what you can to make sure that they get the help that they need.
Yeah. Okay. And that led into my second question when you kind of answered it. But if you have anything to add, on the flip side of that, what are things that you see that are like, dang, they've got a really good support system at home. They did that right. Like,
well, so having a good support system is, having people. You need to have people that know what's going on in your life. You need to have people that you trust with saying, hey, I can't not take too many of them. So who do you know that's responsible, that will be able to, hey, come over in the morning and be like, here's your morning meds, come over in the evening and here are your evening meds. So things like that, people that you know that can be responsible and can step up to the plate when they need to be there. If you know somebody who's not very good about, like, maybe once you asked them to feed your dog while you're gone and they forgot, then they might not be the person who's going to come over and do the medication thing. So knowing who you have in your life that have those strengths, and being able to have people that you can trust to do those things.
Yeah, that's good. Well, thank you so much. I think talking with somebody who's in the trenches is always enlightening, because we don't know what that state is really like if we've never been through it, and we don't know the right things to say or the right things to do or what to, like, we don't know those until we've talked with a professional. And so I know we started talking about the crisis hotline, and it's one of those things that it's there. It's currently still there. I hope that it doesn't go away. I hope it's not defunded. I hope, it is absolutely a life-saving measure for sure. Right. It has its issues. I don't want anybody listening to take it that we're like, nope, it's perfect, but it's something that's there. It's a resource that's out there, and like it or not, it does save lives. So in this country, with the suicide rates back on the rise, we can't really afford to be cutting stuff.
Right. And I don't think, if you ask anybody, regardless of political affiliation or their stance on, what spending we do, nobody is ever going to tell you, oh no, we shouldn't dedicate some resources to suicide prevention. So I really, my hope is that with kind of the spotlight being on some of these crazy funding cuts that have just been done capriciously without any thought of what the damage is going to be, that they're going to be reversed. Because I mean, we're already starting to see some self-correction in some of the areas that they've taken out funding for in the Department of Health, that are returning, and they're rehiring the staff. So, my hope is that the more we advertise this and say, hey, look, this is going on, somebody needs to do something about this, then the more involvement that maybe our leaders on the national level will step in and say, oh wait, no, we can't allow this to happen. We need to maintain this funding. And I think we are seeing some of that, but I do think we need to keep banging this drum for now to make sure that it doesn't get to a point where we're at a critical phase of there's not enough people to answer those phones, and then we go for a period of time before we get all of the resources back in place, and then we're gonna lose people that don't need to be lost. Yeah,
absolutely. I have already done this, but I invite everybody else to do this as well. Call your senators, call your representatives, send them emails, send them letters, whatever it is that you can do. I think there's a 5 calls app or something like that kind of gives you step-by-step instructions. There's so many ways to make your voice heard, and it doesn't take but just a few minutes to do that and actually impact some change on that. So thank you so much again for the work that you do. Thank you for being on the podcast. I really appreciate it. Any parting words for the good of the audience?
No, just, like we were talking about earlier, don't be afraid to ask somebody. If you know something is up, it's okay to just ask them point blank if something's going on. Hey, look, you seem like you're not yourself. Are you okay? And if you really suspect that somebody is, in a really bad place, being able to have that conversation and say, are you thinking about killing yourself? And then being there for them if that's the case.
Yeah, absolutely. Absolutely. Well, thank you so much. I'm so glad that we got to do this.
Yeah.
So if this conversation gave you some clarity or confidence, or even just a new way of thinking about helping someone in crisis, please take a moment to leave us a review, share the episode with a friend, or hit that subscribe button. It helps us find more people to follow the podcast, and it means more lives touched and maybe even saved. And then hop on over to the comments or DMs and let me know, what's one thing you wish you'd known earlier about supporting someone through a mental health crisis. Your insight could help someone else feel less alone, and let's be honest, we're all figuring this out together. And I gotta say, I'm curious because maybe it's something I haven't heard of before. Next week on the podcast, we have Sharon Downs to talk to us about pride, how to be a good ally, and how being a good ally and things like Pride and Pride Month are absolutely suicide intervention measures. So join us next week where we continue to learn how to intervene with ease.